Hello and welcome to Introduction to Mechanical Ventilation. This is Module 1, Ventilator Basics. One common question I get being a respiratory therapy educator from students or nursing students is, what is the purpose that we place patients on mechanical ventilation? Why do we do it? A lot of times, patients present in manners that show labored breathing. A few of these categories overlap that I have on the screen, and there's small technicalities to them. But whenever we see a patient struggling to breathe, a lot of times we want to collect a ABG, arterial blood gas, and look at the values on that. Those values correlate a lot with the need for a mechanical ventilator. Low pHs or being acidotic, less than usually 730, start to get into the area saying that the patient might need assistance. And this is if the pH is becoming acidotic because of high CO2. An arterial blood gas obtains a CO2 value. Whenever the CO2 value starts to increase, the patient becomes hypercapnic and the pH becomes acidotic. If the CO2 becomes too high, the patient can exhibit altered mental status, and it would add to the clinical picture that a patient might need a mechanical ventilator. Another arterial blood gas value is a PaO2, or oxygen content in the blood. This, if it comes back as a low value, would be considered hypoxemia, and this could be another indication for the need for a mechanical ventilator. A lot of these can be classified in terms of respiratory failures, like hypercapnic respiratory failure or hypoxemic respiratory failure, and basically this is what ventilators treat. Another reason we do it is to protect patients' airways. So that patient with a lot of CO2, or ever since the fentanyl epidemic that we've had with patients becoming addicted to narcotics. Narcotics really drop your respiratory rate, drop your respiratory drive, and those patients suffering from overdoses also need protection of airways, because if we do not create a patent airway, they just aspirate into their lungs and cause infection, or even worse, retain CO2 and would not be able to make it. Patients struggling to breathe for days can start to create muscular failure. In this situation, we would intubate that patient to assist their work of breathing and rest their muscles so that they can be treated medically and be able to rehab their muscles, fix their medical process, and be able to be liberated from the vent then. I touched on a few of these values in the last slide. Indications for mechanical ventilation: high CO2, so hypercapnia or hypercarbia, low oxygen or low PO2, so hypoxemia or hypoxia, work of breathing. Work of breathing is a very subjective type of term, and it usually varies from person to person. So usually lab values are needed to correlate with these findings. But as a person becomes more experienced and has more exposure to patients that are working to breathe, you start to see fine aspects of breathing patterns that say this patient's working to breathe. I should be placing them on a mechanical ventilator to rest them. A lot of this requires looking at muscle use and like the sternocleidomastoid muscle or anything like that. You'll get distension of it, and also a lot of abdominal movement. And those are usually pretty good key indicators that a patient might need a mechanical ventilator. Airway protection was touched on in the last one, where a patient can't manage their airway, whether it's due to a neurologic issue or a head trauma or high CO2, maybe an overdose on drugs, anything like that. And then we use artificial airways and place patients on ventilators for medical procedures, because we have to give them sedation during those procedures, and we don't want them to be awake or fill these procedures. Types of airways we use with the ventilator. The most common type would be an endotracheal tube. There are many variations of endotracheal tubes, many features that different manufacturers have, but despite all that, they all boil down to being an endotracheal tube that can be placed through the mouth, goes down the tracheal tract. It involves a cuff that helps to seal off the lower lungs and airways from the upper airway, and it allows the tube to exchange air from the ventilator. There are specially designed tubes called nasoendotracheal tubes. These are curved. They are on the right side of the screen right here. I'm sorry, my drawing's not the best, but these are specially curved to be placed through the nasal passage and go down to the lungs. This could be indicated for a patient that has maybe oral trauma or anything like that. It was in a car wreck, maybe a huge mass or tumors occluding their mouth, and an endotracheal tube cannot be placed orally. The other one is patients that are on the ventilator for a long period of time often need tracheostomy tubes. Critical care medicine is recommending that you should place tracheostomy tubes on patients earlier. This is for better vent liberation, or taking the patient off the ventilator quicker, because you eliminate the need for high levels of sedatives to make the patient comfortable due to all the sensation of an endotracheal tube in the mouth, and you're able to wake this patient up and rehab them more quickly to get their muscle tone back. In emergent scenarios, a patient may get a cricothyrotomy tube. This is usually a very, very small passage that was only placed because no other method of an airway could be placed. And this is a very rare situation this would happen, but it would happen, and a patient then would need to be placed on a ventilator until another airway could be placed. And then LMAs are typically seen in the surgical world. They usually don't make it to floor or intensive care settings, but these are often placed by anesthesia doctors and removed at the end of procedures, and usually the people or the patient has no idea that they even had this airway in. In an earlier slide, we talked about arterial blood gas values. A lot of times I get asked what are indications for arterial blood gas or an ABG. I like to get these, and the more seasoned you become, the less you'll need an ABG, because you'll realize fine aspects of patients that are telling you what their lab values are. But a lot of times affiliates or doctors will order ABGs to assess respiratory distress. The patient is looking in distress, and we want to know the values to know what we need to do. And a lot of times when a patient's in respiratory distress, I find it kind of cruel to just see how bad it is, and I'd rather treat and then get the blood gas. And then if I'm not doing the job there, then I escalate what I'm doing, or make more aggressive treatment. So if I notice a patient's in respiratory distress, I may place them on a BiPAP that's going to help ease their breathing, and then I'm going to get an arterial blood gas to see where the value is, And then depending on how the patient responds or my blood gas value, that tells me what I need to do, if I need to be more aggressive, or a BiPAP's work can give me a little time for the BiPAP to work. Another reason that we look at ABGs is for presentation of illness known to precipitate acidosis or hypoxia. This just means that CO2 may be too high and it's making the blood gas pH drop down below 735, so the patient's becoming acidotic, or the bicarb is starting to drop, the HCO3 is starting to drop less than 22, and bicarb has a lot more effect on pH with changes in small intervals than CO2. So just dropping from 22 to 20 can move your pH a lot with just an increment of 2 compared to maybe a CO2 where that would take 10 points to drop your pH to 730. Another reason, I kind of talked about this, is to assess the responses to interventions. Interventions can come in a wide variety. BiPAP machine, let's say we placed a patient on a ventilator due to a bad blood gas, and we want to see how the ABG is doing. Other things like dialysis can improve blood gas, removing fluid over time to help alveolar space in the lungs, create more efficient CO2 and oxygen exchange. There is a wide variety of things, interventions that we do that could be assessed with an arterial blood gas. And then another kind of thing that can be a little bit of a, we need to understand how this procedure is done and how we get this value. A lot of times, unless you have an arterial line, involves sticking a patient with a needle. So we don't just get this value just to see what the patient's blood gas is. This should only be indicated if you suspect that you are needing to treat a patient, or you need the value to know what it is before you're extubating a patient or progressing a patient. It really shouldn't be something that you just do just because you want to know. So the next thing we're going to look at is ventilator settings. I have a screen here of a Servo-I ventilator, and it can be hard to see. I'm not sure how well you can see it, but basically, depending on where you work and what ventilator you work with, this is going to look a lot different. I'm going to go over the essential things that most mechanical ventilators have that will help you understand this a little bit better. So the first thing, and I know these Servo-I's very well, the first thing that we see here is this bottom bar. And this bottom bar correlates with these tabs down here, and they'll change these values. So the one I highlighted here is the oxygen content that's added to the circuit for the patient to breathe in. Room air is 21% oxygen. Before I covered this up, this was 35% oxygen. So that's pretty low compared to being at 100% or anything like that. The next value is PEEP. PEEP stands for positive end expiratory pressure. PEEP is often correlated with alveolar surface area in the lungs, and it's responsible for helping the patient oxygenate. So dumping oxygen into the circuit can help a patient oxygenate, and then also collapsed alveoli cause inability for oxygen to bind with hemoglobin, so you have to physically open the alveolar sacs with positive pressure, usually in the form of PEEP, to help get oxygen in the blood. PEEP values can range depending on how bad the patient's doing or how well the patient's doing. A normal person walking around has a PEEP value of 5. My hospital protocol, any other hospital protocol, usually prefers a PEEP of anywhere from 8 or less before they would pull a patient off the ventilator. The next value that usually hangs right next to that PEEP value would be respiratory rate. So in a control mode, you set a respiratory rate for the patient. A normal person breathes at 12 to 20 breaths per minute. This could be varied, the set value that you would pick based upon things like ABG or anything like that. But usually when a patient started out on a ventilator, it's mid-teens to maybe almost 20, and then an arterial blood gas collected and adjustments are made from there. The next value here is pressure support. So this is depends on the mode that a patient is on, but pressure support is basically the change in pressure above PEEP value that exchanges volume in and out of the lung. So tidal volume is something that we set for a patient. If you could imagine a balloon that's blown up, that has if it were liquid, I think people see it when it's liquid as a volume, but since it's air, they don't understand it as a volume sometimes. If you can measure the amount of air in a balloon, that's a lot like the lungs. That would be tidal volume. Depending on the mode, often depends on how you get tidal volume. But no matter the mode, a patient's getting tidal volume to help exchange air in and out of their lung. This top bar up here, it's hard to see, it says 14, is peak inspiratory pressure. That's the maximum amount of pressure that's in the lungs when a patient is delivered a breath from a ventilator. The next one down is the measured PEEP in the circuit. So things like water in the tubing or anything like that can throw off the actual PEEP, and you would get an alarm from that and you'd be able to troubleshoot what's going on. The next one down is mean airway pressure. Mean airway pressure is the average pressure in the circuit over the minute of being on the ventilator. And it's often, I use it to correlate how well I'm treating a patient with positive pressure. And that's something we'll get into in later modules. The next value is, they're kind of hard to see, but one is the oxygen delivery. That's a backup mechanism that basically just verifies that you're getting the oxygen content that is set. The next is inhaled and exhaled minute ventilations. So minute ventilation is respiratory rate multiplied by tidal volume. A lot of people correlate this value with CO2. You have inhaled and exhaled tidal volumes as your last fields there. And these are the main vent settings that you're going to see. Some of these are measured, and some of these you're actually going to set. So often people wonder how treating hypoxemia works on a ventilator. The most essential thing that a respiratory therapist is going to do to treat hypoxemia on a ventilator is increase the oxygen value. There's a rule called refractory hypoxemia. This rule means if I get to 60% oxygen and I am not treating hypoxemia for a patient, then I should think that 70, 80, 90, 100% oxygen is not going to work for this patient. Then I should be doing other physical things to help dilate the alveolar sacs to help oxygen get in the blood. This would involve increasing mean airway pressure. Mean airway pressure is achieved by increasing PEEP values or increasing I time. So the amount of time that it takes for you to inhale, if it's elongated, will increase interthoracic pressure, just like increasing PEEP, and help to recruit your alveoli. Another way we can increase hypoxemia, and it's not really the way I overly recommend, is increasing minute ventilation. So if you're sweeping air in and out of the alveolar sac more quickly, then you're exchanging more CO2 and you're making a more oxygen rich environment. When these methods don't work, you should consider changing your vent modes. There are ventilator modes that work better for recruiting alveolar surface area, like APRV or bivent, or pressure control modes. These modes take a little practice, but they are really beneficial for helping patients that have hypoxemia. When these devices don't work, a lot of times hospital facilities will go to good lung down, GLD, or proning. What this does is this moves blood flows to more effective regions of the lungs. It basically creates a change in VQ mismatching. A lot of patients laying on their back, disease processes or aspirated bacteria or anything like that goes to their lower dorsal or back regions, and it affects those lung areas. And since they're on their backs, gravity shunts blood to those areas more efficiently. So we need to use gravity, prone them, or place them on their belly, and that will shift blood flow to more effective, more better regions of the lungs that haven't been affected by bacteria or anything like that. Inhaled prostaglandins is another thing that has support in critical care medicine when treating acute respiratory distress syndrome. So this will work by nebulizing Velletri or Iliprost or inhaled nitric or anything like that was treated for pulmonary hypertension. This goes to the vessels in the lungs, dilates them, and allows more blood flow through those dilated lungs, and it helps oxygen then be able to enter those vessels in exchange with hemoglobin. And then the last management tool you have is basically placing a patient on ECMO and cannulating them, where blood is pulled out of the body, ran through a machine, CO2 is removed, and oxygen's added to the blood and ran back into the patient. And it's a very invasive process where the patient's going to usually spend at least a week if they're in ARDS and require a long rehab process.